A very good evening and a very warm welcome to all attending doctors for this program today, which is very aptly titled Redefining Acid Peptic Disorder Management, the Role of Vonoprazan. Now, while we will try to redefine the acid peptic disease management, an important candidate which has emerged recently as a drug option for the management is something which will be deeply dived, where there'll be a deep dive into the data around this. Now, for this program, we have the who's who from across the country, and we have a very prominent international speaker from Singapore to discuss, to basically give us a huge scientific perspective and dimension. Now, before we proceed, I would like to take you through a short presentation, which is our corporate presentation for Ajanta Pharma. Basically, being associated with healthcare practitioners like yourself, I would like to take this update to tell you about the status of Ajanta Pharma at this point of time. Now, Ajanta has been serving healthcare needs globally for the past 50 years. It is an Indian multinational pharmaceutical company which serves global healthcare needs through empathy, innovation, and technology. An Indian multinational company in the true sense of the word because it operates in 30 plus countries with 500 plus products and people from 30 plus nationalities working in the company. Now, what really distinctly sets us apart within the space of Indian pharmaceutical space is an advanced R&D center, which is truly a big differentiator. This is located very much in Mumbai, an area of 1 lakh square feet with 750 plus scientists working associated with the Advanced R&D Center. And this Advanced R&D Center ensures the complete value chain in terms of development of pharmaceuticals from formulation up till the synthetic development. Now, we have manufacturing plants, which are 7 state-of-the-art manufacturing facilities across India. 2 of them have US FDA approval, which are shown here, Python and Dahej, and the remaining 5 have approvals from various other regulatory agencies and bodies. Now, our differentiation really has been that in the past decade, that is in the past 10 years, we have been able to achieve 150 plus first time in India products. Now, while our focus has been very centric around 4 therapies, these are the brands which you can see, okay, which is a strong presence within the prominent brands which you must have been exposed to at some point in terms of clinical practice. Within the pain and gastro segment specifically, I would like to state Feburic is something which is known, Febuxostat, Volstar, which is the Vonoprazan, okay, and Vertizac. So this has been the unique differentiation in terms of bringing first time in India and strong presence within the 4 concentrated therapy areas. Now, because of being closely being associated with healthcare practitioners with close guidance, close association support, we have been able to achieve a lot of awards and recognition, some of them shown on the slide. Now, prominent amongst these was the Time Magazine Young Maker of the Year Award, which was received from the very Honorable Prime Minister of India, Shri Narendra Modi ji. Also, our recent awards and recognitions are shown on the slides here. Deloitte Best Managed Companies, the Golden Peacock Business Excellence Awards are some of them. While we truly believe in striving to be your scientific partner, today's event is one such small step in the direction of being your scientific partner. And to bring us back to the program, as mentioned initially, I would like to start the program by giving an introduction for today's very prominent panel. Just a minute. Giving an introduction to today's very prominent panel. To start with, I would like to welcome amongst us as moderator, Professor Dr. Sandeep Nijavan. As I mentioned, we have the who's who from across India. Professor Dr. Sandeep Nijavan is the moderator for today's program. Sir is very well known from the SMS Medical College, Jaipur. Senior professor and HOD at the same college with the Department of Gastroenterology. Sir is the national president for the Indian Society of Gastroenterology. Warm welcome to you, sir.
Thank you so much. Thank you.
As panelists, we have with us again an esteemed panel. We have Dr. Ramesh Ruprai. Sir is a DM Gastroenterology from AIMS, New Delhi, and the director at Rai Specialty Center and Research Center, Rai Specialty Care and Research Center, Jaipur. Warm welcome to you, sir.
Thank you.
Our next panelist is Professor Dr. Chetan Kantharia. Sir is the professor and HOD of gastroenterology at the KEM Hospital and Medical College. In addition, he is academic convener at various societies and various bodies. Warm welcome to you, sir, Dr. Kantharia, sir. Our next panelist is Professor Dr. Girish Kumar Pati, the HOD for Postgraduate Department of Gastroenterology and Hepatobiliary Sciences for Gastroenterology at IMS and Some Hospital, Bhubaneswar. Warm welcome to you, sir, Dr. Girish Kumar, sir. Our next panelist is Dr. Sharat Kote. Sir is a senior consultant, medical gastroenterology, hepatology, and nutrition at the Sati Care Hospital, Bangalore. Now, of course, all of them are very distinguished, and in interest of time, I have not taken a detailed introduction of their CVs. I would like to request a moderator, Dr. Sandeep, sir, to introduce our international speaker for today.
Thank you so much, and good evening to everyone, all my panelists and speaker for today, Dr. Ang, and all the delegates who are actually joined for this webinar. Dr. Ang is a director of motility service at Changi General Hospital, Singapore. She is a senior clinical lecturer, faculty of medicine at National University of Singapore. She is a member of Gastroenterology Society of Singapore. She is a physician faculty at Singapore Health Gastroenterology and Internal Medicine. She is senior clinical lecturer at NUS Yonglou Lin School of Medicine. She is a committee member of 2021 Rome Assessment and Outcome Committee for Functional Bowel Diseases. She is the principal investigator for H. pylori trial, very famous trial for Vonoprazan 7 days versus 14 days trial. And she has been a recipient of several awards like Singapore Health Quality Service Award, Outstanding Faculty Award, GI Motility and Review Recognition Award. And she had been a prominent speaker at various platforms globally. So welcome, hearty welcome to you, Dr. Ang. And I'll now hand over the further proceedings to Dr. Ang for her talk.
Just getting my slides ready. Okay. All right. Can you see my slides?
Yeah, we can see your slides.
Yes, ma'am.
Okay.
Perfect.
Yeah. Okay. So, a very good evening to everyone. I would like to thank Ajanta Pharmaceuticals for the kind opportunity to speak, and to the panelists and the moderators for the very kind introduction. So, as mentioned earlier, this evening we'll be talking about redefining acid peptic disorders management with the role of Vonoprazan. Here's a brief outline of my talk. I will speak briefly on the prevalence of acid peptic disorders, the limitations of current treatment with proton pump inhibitors, focusing on the mechanism of action of Vonoprazan, which is a potassium competitive acid blocker, so as to understand how it's a beneficial effect way over and above existing proton pump inhibitors, looking at the role in Helicobacter pylori, gastroesophageal reflux disease, and a smaller role in peptic ulcer disease. And lastly, we'll look at some safety issues. So acid-related disorders result from distinct but overlapping pathogenic mechanisms that involve acid effects on the esophageal, gastric, and duodenal mucosa with diminished defense. And one of the most common acid peptic disorders is that of gastroesophageal reflux disease. And in an earlier study of a US Gallup survey of over 1,000 subjects, it showed that close to 78% had nighttime GERD symptoms. And this is quite significant because it significantly impairs the quality of life in these patients, and a substantial proportion of patients have nighttime reflux, a total of 78% based on a poll of US subjects. So patients with more severe reflux disease have actually been shown in studies to have higher levels of nocturnal acid exposure. And the treatment goals have traditionally been related to symptom relief, mucosal healing, prevention of complications, and prevention of the recurrence of erosive reflux esophagitis. In fact, results from a meta-analysis have shown that the healing rates from erosive esophagitis is directly related to the suppression of gastric acid secretion over 24 hours. And over here, we see a linear relationship between the duration of intragastric pH above 4 and the proportion of patients who have healing of erosive esophagitis, with a significant correlation coefficient of 0.87. And similarly, we see an inverse relationship. The longer the duration of the intragastric pH is above 4, the shorter the duration of the intraesophageal pH less than 4. And similarly, the longer the duration of the intraesophageal pH time being less than 4, the fewer the percentage of patients being healed. So it is really intuitive that the longer the duration of which we suppress the intragastric pH levels, the shorter the duration of the intraesophageal pH remains at an acidic value. So these studies have shown a linear relation. Similarly, for acid suppression in duodenal ulcers, complex physics models have shown that the relationship between the healing rates of duodenal ulcers is related to the duration of acid suppression and the threshold pH values, where over here we see the healing rates at 2 weeks, 4 weeks, and 8 weeks. And what this meta-analysis showed was that it is required to maintain an intragastric pH of above 3 for more than 18 hours a day at 4 weeks to achieve healing of duodenal ulcers. So we've seen acid suppression that is required for the treatment of reflux disease, duodenal ulcers, and also in the treatment of Helicobacter pylori. What we will see in this diagram is that Helicobacter pylori survives at a broad pH range of between 4 and 8. However, at a more acidic value of a pH of between 4 and 6 and 5, the Helicobacter pylori are resistant to antibiotics. They are not replicating, but they just remain in the acidic milieu of the gastric parietal cells. However, if we were to increase the gastric pH to above 6, to the region of between 6 and 8, this allows optimal proliferation of the Helicobacter pylori, where it transitions from a stationary phase to a logarithmic phase of growth. When it's multiple proliferation, it renders it maximally susceptible to the growth-dependent antibiotics. So we see that an optimal range of the gastric pH of between 6 to 8 allows it to be maximally sensitive to the growth-dependent antibiotics. And this study has shown that it is required or recommended to maintain an intragastric pH of above 5 for more than 18 hours. So coming back to a bit of physiology, some of the major milestones in our understanding of gastric acid secretion and the treatment of acid-related disorders in the last 50 years have been the discovery of the histamine receptors and the development of H2 antagonists in the 1970s, the identification of the H plus potassium ATPase as the final common pathway of acid secretion, and lastly, the identification of Helicobacter pylori as a major cause of peptic ulcer disease. So this is a snapshot view of the complex structure of the proton pumps. In the resting state, the proton pumps are in tubular vesicles hiding within the cytoplasm of the gastric parietal cells. And this is a schematic diagram of the proton pump. It is a complex structure a heterodimer composed of alpha and beta subunits. And the alpha subunit has 10 transmembrane portions, of which one of the transmembrane is the binding site of the proton pump inhibitor. So just to remember that in the resting state, the proton pumps are in the vesicles, and when activated, they insert themselves into the membrane in order to secrete H+ into the parietal cell. And just to recap, the mechanism of proton pump inhibitors is a 3-step process. Proton pumps need to be activated by acid, and therefore they need to be taken around about 30 minutes before a meal. They are activated in the gastric cells, and they undergo acid-catalyzed conversion into a sulfonamide intermediate, followed by an irreversible bonding with the cysteine residues exposed on the luminal membrane of the proton pump. This is a 3-step acid-catalyzed conversion involving an irreversible covalent bonding, cystic residues leading to blockade of the proton pump and in turn inhibiting acid secretion. So you can imagine that this 3-step process involving covalent bond takes time, and it takes time to achieve adequate drug levels in the bloodstream. So looking at the summary of the pharmacokinetics of the different proton pump inhibitors, we see that most of them suffer from having a rather short half-life of between 0.5 and 2 hours. When considering the pharmacokinetics of PPIs, the area under the plasma concentration curve, or the AUC, is directly related to the acid inhibitory effect, whereas the half-life allows us to determine the duration of action of the drug. And what we see is that regardless of the type of proton pump inhibitors, they all have rather similar pharmacokinetic properties, which is a short half-life and relatively low AUC values. So looking at a summary of the limitations of proton pump inhibitors, we see and mention that the short half-life of PPIs is in adverse connection to that of the longer half-life of proton pumps, which have an average half-life of 50 hours. So the gastric proton pumps have a half-life of 50 hours, and they are continuously being replaced every day. Up to 1/3 of proton pumps are replaced by new biosynthesis every day. And these proton pumps are constantly in the state of regeneration, and this is opposed to the short half-life of proton pumps. And this explains the phenomenon of nocturnal acid breakthrough. And if you recall the earlier Gallup survey, where a substantial proportion of patients have reflux symptoms even at night, and this has been attributed to the phenomenon of nocturnal acid breakthrough, where the proton pumps are regenerated, they continue to secrete acid, but this is way after the mechanism of action of proton pump inhibitors. And we've seen that the PPIs need gastric acid for activation, followed by the covalent bonding with the cysteine residues. And therefore, there's a delay in the onset of action, taking approximately between 3 to 5 days to reach full capacity. And in addition, it needs to be taken at appropriate times relative to the meals. And we are aware that there is marked inter-individual variability of the pharmacodynamics due to cytochrome polymorphisms, with extensive metabolizers of CYP2C19 being rather common, especially amongst Asians. And let's look at the mechanism of action of Vonoprazan, which is a potassium-competitive acid blocker. It is a new class of medications that provides a promising alternative to PPIs. It works as a different mechanism. In opposed to PPIs, it is a reversible competitive antagonist of the H+ potassium ATPase pump, which I will show in a subsequent slide. It has a rapid onset of action, and it achieves suppressive effect independent of the proton pump status, because it is able to bind to both active and inactive proton pumps. And here, as shown, this is a recap, and this diagram illustrates the mechanism of action of potassium-competitive acid blockers. And if you recall that the H+ potassium ATPase pump is the final common pathway of acid secretion. It exchanges H+ in addition for the uptake of potassium. What the PCAPS does is that it competitively binds and competes with potassium for the K+ binding site. Once it displaces potassium, it prevents the secretion of H+ into the gastric parietal cells. This is rapid and reversible inhibition and its action is immediate. It elevates the gastric pH to much higher levels than what the PPIs do, and it's able to exert its full effect within the first day of use. And because it's a weak base with high pKa values, it's able to achieve high accumulation and retention in the gastric parietal cells. And in addition, it is metabolized by CYP3A4. It's less affected by polymorphisms of CYP2C19, and pharmacodynamic studies have shown that it's able to maintain an intragastric pH of above 6 within the first day of treatment. And if you recall that we want an optimal pH in order to have maximal antimicrobial activity, especially in the treatment of Helicobacter pylori. Just to recap the mechanism of action, if you recall in the secretory canaliculus, in the quiescent state, parietal cells and the tubulovesicles, the inactive proton pumps are sitting within the cytoplasm of the tubulovesicles. When activated by a meal, it inserts itself into the apical membrane of the gastric parietal cells, and proton pump inhibitors can only work on activated proton pumps that are inserted into the membrane portion of the parietal cells. However, proton pump inhibitors are acid unstable, they do not stay long, and they have a short half-life. This is in contrast to vonoprazan, which is a PCAB that can bind to both active and inactive proton pumps. And if you can see, the vonoprazan binds to the inactive proton pumps within the cytoplasm as well as to the activated proton pumps. And it hangs around in the gastric cells for way longer than proton pump inhibitors, allowing it to exert a duration of action way past that of proton pump inhibitors. And this can be nicely illustrated in this diagram showing the pharmacodynamics of PPIs. And if you recall, because it requires a 3-step acid catalyzed conversion, it's got a short half-life, you need an approximate 6 doses of average of 3 days to achieve maximal drug levels, as opposed to the potassium competitive acid blockers, where you can achieve high levels within the first dose of treatment. And this is elegantly illustrated way back in the phase 1 studies of vonoprazan, looking at the pharmacodynamic profile of vonoprazan in healthy volunteers, both amongst Japanese subjects and the UK subjects. And within the first day of treatment, regardless of dose of vonoprazan, dose increased from 10 to 40 milligrams, you see a rapid rise of the intragastric pH after the first dose of treatment. And within 4 hours, all doses of vonoprazan had achieved very high pH levels, around about 7. And similarly in the UK subjects, high pH values, this is in contrast to the placebo, where you see that the pH levels remains way below 4. And even amongst day 7 of vonoprazan, we see that even before the dose, we have a high levels achieved throughout, both for the UK subjects as well as the Japanese subjects. So putting these into summary, comparing the pharmacokinetics of PPIs and vonoprazan, the beneficial effects of vonoprazan lies in its much longer half-life, a shorter time to peak plasma levels, higher AUC values, and this tends to improve the treatment of acid-related disorders. And just a brief recap of some earlier studies from Japan, where they compared the acid suppression with vonoprazan versus esomeprazole or Nexium. These were healthy volunteers in a randomized open-label crossover study, where vonoprazan was compared to Nexium with a 7-day washout period. And you see that within the first day of admission and as well as in the day 7 of administration, the gastric pH holding time value, which is the proportion of time that the gastric pH remains above 4, was significantly higher in vonoprazan compared to esomeprazole, both within first day and 7 day of administration. And this distinction remained both in the daytime and nighttime. We have talked about nocturnal acid breakthrough. So the benefits of vonoprazan as opposed to esomeprazole was that both in the daytime and nighttime, the gastric pH 4 remained above 4 for significantly higher proportion of time. So comparing PCABs versus proton pump inhibitors, just to summarize, maximal acid suppression occurs within 1 day, as opposed to 3 to 5 days for the proton pump inhibitors, full effect within 1 administration, independent of meal timing, and because it's a reversible ionic competitive inhibitor to displace the potassium pump, its effect is rapid, it's got a longer half-life, and this translates to better clinical effects. So let's look at how the pharmacodynamics and pharmacokinetic benefits of Vonoprazan translates to clinical use, and we'll focus firstly. Be aware, Helicobacter pylori is a class 1 carcinogen and of significant healthcare importance because it has an overall global prevalence of close to 50%, with Southeast Asia featured here, for which Singapore and India will feature within here. However, this was just a snapshot view, but what is more worrying is that in this study, looking specifically at the prevalence of Helicobacter pylori in India, we see a prevalence of between 53 and 74%, which is indeed a significant healthcare concern within India. Existing guidelines, whether it's the Toronto Consensus, the Maastricht guidelines, the ACG guidelines, and lately the Japanese Society for Helicobacter Research, have concerns with the prevalence of clarithromycin-resistant strains of Helicobacter pylori and its effect in reducing the efficacy of conventional first-line therapy, which is conventionally amoxicillin, clarithromycin, and a proton pump inhibitor for 2 weeks. And what is significant is that in the latest Maastricht consensus, they have stated that the use of potassium competitive acid blockers is superior or not inferior to conventional PPI-based therapies for both first and second-line treatment, and potentially superior in patients with evidence of antimicrobial-resistant infections. The Japanese have been the key players in the role of PCABs. And however, the Japanese have actually been using 7-day triple therapy with PPIs or a PCABs, and they are now using first-line PCABs in a 7-day regimen for Helicobacter pylori treatment in Japan, endorsed by the Japanese guidelines. Just to briefly recap, that the factors influencing the outcome of Helicobacter pylori eradication are multiple, whether it's host factors or virulence factors of the Helicobacter pylori, such as the CAT-A and VAC genes. The potency of acid suppression is something that Vonoprazan can potentially help to overcome. And in addition, what is more important is the rising prevalence of Helicobacter pylori resistant strains, particularly to metronidazole and especially to clarithromycin. And in this study, a systematic review and meta-analysis of the resistance patterns of Helicobacter pylori in South Asia, of which includes Bangladesh, Bhutan, India, Nepal, and Pakistan, from the time of 2003-2012 and a more recent time frame, we see an overall resistance to clarithromycin of 30%. However, more recently, focusing only within the 6 regions of India, we see that the prevalence rates of clarithromycin resistance actually varies within the different regions of India, and overall the prevalence of clarithromycin resistance in India is close to 36%, which is something to worry about. And a recap, as the potency of acid suppression in Helicobacter pylori is particularly important in order to allow the Helicobacter pylori to have maximal proliferative actions and allowing it to be susceptible to the growth-dependent antibiotics. Over in Singapore, just to briefly discuss the study that I have performed, slightly different, not sure the India health system, but in Singapore, I work in a public hospital system where a substantial proportion of my patients are from the working class. Very few are from the private paying class. So working amongst patients from the subsidized population, the working class, has given me the unique opportunity to perform a randomized controlled trial. And in designing this study, there was various factors that I had to consider. In Singapore, we do not have the benefit of branded generic. Our Vonoprazan does cost a lot. So I was able to obtain funding to use the actual Vonoprazan from Takeda Pharmaceuticals. We don't have generic for that. And I compared the use of Vonoprazan with conventional PPI therapy. And the reason why I chose a 7-day regimen, which means amoxicillin, clarithromycin, and Vonoprazan for 7 days, was twofold. Mainly, I wanted to look at whether Singaporeans could tolerate a 7-day treatment because of the very promising results from Japan, where 7-day treatment is the standard of care. And also because of the cost issues, I could not afford to use 14 days of Vonoprazan. So the comparison was conventional 14-day PPI therapy with amoxicillin, clarithromycin, and a PPI, whether it was generic Losec, generic Nexium, or generic Period, and compared that with 7-day amoxicillin, clarithromycin, and Vonoprazan. So this was a controlled study. We initially had 244 subjects in the intention to treat analysis, and in the per protocol, we had 225. We designed it as a non-inferiority study with a non-inferiority margin of 10%. So in the intention to treat analysis, we found that the eradication rates for Vonoprazan was 87.4% and 88% in the PPI arm of the study. However, in the per protocol analysis, the Vonoprazan treated arm achieved an eradication rate of 96.3% as opposed to 94%. And the difference in eradication rate is as shown, and the lower margin of the 95% confidence interval was within the 10% non-inferiority margin. So we achieved the primary outcome that the non-inferiority of 7-day Vonoprazan compared to 14-day conventional PPI treatment. So this was the per protocol analysis. We achieved our primary outcome of showing the non-inferiority of Vonoprazan. If we further look at the sensitive strains, we did susceptibility testing for 187 patients, of which 83% were clarithromycin susceptible. And this diagram illustrates the success rates in the intention to treat analysis and the per protocol analysis for those subjects who had classic-resistant strains of Helicobacter pylori, and we achieved 98.6% with Vonoprazan and 97.1% with PPI. Again, the lower margin of the 95% confidence interval falling within the 10% non-inferiority margin. However, we were not able to achieve the outcome studies for the clarithromycin resistant strains. Amongst the cohort of our patients, we had 17% prevalence of clarithromycin resistance. In the Vonoprazan treated arm, 83.3% successful eradication rate despite clarithromycin resistance, as opposed to 81%. So numerically, Vonoprazan achieved 83.3%, but because perhaps our numbers were small, our lower margin of the non-inferiority 95% confidence interval was above 10. So this was not achieved in terms of the secondary outcome. But overall, very favorable results simply with 7 days of Vonoprazan. And our study and other randomized controlled studies was recently published in a meta-analysis and systematic review, putting together a summary of the randomized controlled studies comparing Vonoprazan with PPI-based triple therapy for first-line HP eradication, and we see a favorable benefit of 1.09 in favor of Vonoprazan. However, and this is seen in both the intention to treat and the per protocol analysis, overall beneficial effects of Vonoprazan. However, if we further divide this subgroup analysis for clarithromycin susceptible strains of PPIs, of which 4 studies, including ours, were included, there was no significant difference between Vonoprazan versus PPIs amongst classic susceptible strains. But what was more significant was that if we looked only at the clarithromycin resistant strains of Helicobacter pylori, we see a significant benefit of Vonoprazan compared to PPI-based triple therapy. And this is regardless of whether the studies were 7 days Vonoprazan or 14 days Vonoprazan. So this is particularly important perhaps in India, where we see close to 30% resistance rates for clarithromycin. So putting all together, susceptible and resistant strains, significant benefits of Vonoprazan compared to PPI in the most updated systematic review and meta-analysis for studies that compared Vonoprazan versus PPI for first-line Helicobacter pylori eradication. And just to mention that cost benefit is an important consideration for Helicobacter pylori eradication. The study from Japan, where close to 1.5 million patients receive first-line HP eradication annually, was a retrospective observational study using data from a large-scale nationwide health insurance claims database. And amongst propensity score matched patients, those who received PCAP treatment had higher eradication rates compared to those with PPI-based regimen, and that translated to lower costs in terms of the Japanese yen. So not much per patient, but if you multiply it by 1.5 million patients on the health insurance network, it translates to a significant cost benefit. Moving on to the second broad category, which is the use of Vonoprazan for gastroesophageal reflux disease. Again, a very recently published systematic review and meta-analysis comparing PCAPs versus PPIs and placebos in gastroesophageal reflux disease shows an overall effectiveness rate of 1.73 for PCAPs compared to PPIs or placebo, and a significant odds ratio for healing rates in favor of PCAPs. And not surprisingly, the adverse events were not different between PCAPs versus PPIs and placebos. So this study was a recently published study where they compared Vonoprazan with lansoprazole for the healing of all grades of erosive esophagitis. The systematic review and meta-analysis included 4 studies, 2 from Japan, 1 from China, and 1 from the USA, incorporating over 2,200 subjects who were randomized to receive Vonoprazan versus lansoprazole in the healing of grades A to D erosive esophagitis. And overall, significant benefits of Vonoprazan compared to lansoprazole was seen at 2 weeks and 8 weeks of treatment. However, on subgroup analysis, they did not see a difference for those with mild grades of erosive esophagitis, LA grades A and B, but they found a significant beneficial effect of Vonoprazan compared to lansoprazole throughout the study, both at weeks 2, 4, and 8, for those with more severe grades of reflux esophagitis. It is always important for the initial relief of heartburn. Most patients who are treated with PPIs will often tell you that it takes a few days for their PPI to exert effect. And this small study from Japan looked at the onset of relief of heartburn, where 32 patients with erosive esophagitis with symptoms of heartburn for more than once a week randomized to receive Vonoprazan or lansoprazole, with the primary endpoint being the first day of complete daytime and nighttime heartburn relief for 7 consecutive days. Significantly more patients achieved complete heartburn relief, hazard ratio of 3.58 with Vonoprazan compared to lansoprazole. However, on subgroup analysis, the significance was seen mostly at night. More patients achieved nighttime relief of heartburn symptoms and a tendency to significance for daytime heartburn relief, but nevertheless, significant beneficial effects of Vonoprazan as opposed to lansoprazole. A very recent study that has been published in the USA, the article is in press, is the use of Vonoprazan in non-erosive reflux disease, which actually is a significant problem amongst Asians as well as Caucasians. Multi-center study in the US, over 776 subjects with non-erosive reflux disease were randomized to receive placebo, Vonoprazan 10 milligrams, or Vonoprazan 20 milligrams for 4 weeks. And after 4 weeks, there was an extension phase of the study where those with Vonoprazan continued on the same dose, whereas those with placebo were re-randomized to receive either 10 milligrams or 20 milligrams of Vonoprazan. The inclusion criteria were adult patients with heartburn for at least 6 months, with symptoms for at least 4 consecutive days in a week during the screening period, absence of erosive esophagitis on endoscopy, and here were the results of the study. The primary endpoint was the percentage of subjects with complete heartburn relief, both in daytime and nighttime. And we can see that regardless of the dose of Vonoprazan, whether it was 10 milligrams or 20 milligrams, significantly higher numbers of patients achieve complete heartburn relief compared to placebo. And if you recall the extension phase, where after the initial treatment period, the placebo-controlled group were then re-randomized to receive vonoprazan and all achieve significant benefits in terms of daytime and nighttime heartburn relief on vonoprazan. So this study was a landmark study to show the beneficial effects of vonoprazan amongst non-erosive reflux disease. Moving even further, a more novel treatment for vonoprazan is the use of on-demand vonoprazan. However, this is a very strict inclusion criteria. This was a randomized, double-blind, placebo-controlled trial involving over 54 US sites, over 450 patients with non-erosive reflux disease, and the screening period identified adult patients, symptoms of heartburn for more than 6 months, recurring symptoms for more than 4 days per week. During the run-in period, they were given open-label vonoprazan, 20 milligrams for 4 weeks, and they were required to be responsive to vonoprazan with the complete absence of heartburn during the last 7 days of vonoprazan in the run-in period. And once they fulfilled this criteria, in addition to being compliant with symptom diaries, requiring them to feel the symptoms both in the daytime and nighttime, they were then randomized to receive on-demand vonoprazan at different doses of 10 milligrams, 20 milligrams, or 40 milligrams of placebo, a 4-arm study where if they experienced heartburn during the study, they were required to key in the electronic diary and also to key in the symptom diary every half an hour after taking the drug, which means, for instance, if they were randomized to receive vonoprazan and if they experienced symptoms, they would then key in the time of the symptom. They would then immediately take the study drug and religiously record how long it takes for the symptoms to be relieved. And you can see that within 3 hours, substantial proportion of patients, 56% amongst those receiving 10 milligrams of vonoprazan, 60% in those receiving 20 milligrams of vonoprazan, and 70% in those receiving 40 milligrams of vonoprazan achieved the primary endpoint, which is the percentage of heartburn episodes that were completely relieved within 3 hours and with a sustained relief for 24 hours. Significant beneficial effects for on-demand vonoprazan compared to placebo. So this has shown that vonoprazan was shown to benefit not just non-erosive reflux disease in Lauren Lane's study, but this study went further to show that vonoprazan can be beneficial in an on-demand basis version. Some small studies from Japan have looked at the efficacy of vonoprazan amongst patients who have PPI refractory erosive reflux esophagitis. Multi-center study from Japan identified 90 patients who failed to respond to conventional PPIs. They were then given lansoprazole in the run-in period, 30 milligrams for between 7 to 14 days. They underwent endoscopy before recruitment to confirm the presence of ongoing erosive esophagitis, and they underwent baseline pH studies before and after being randomized to vonoprazan, with the primary endpoint being the intraesophageal and intragastric pH values on vonoprazan, and the secondary endpoint with a repeat endoscopy at 8 weeks after treatment with vonoprazan. This diagram shows an example of the intragastric and intraesophageal pH values in a patient with LA grade B erosive esophagitis. This is the gastric pH over 24 hours and the esophageal pH. The line in dark is what happens after giving vonoprazan. We see a substantial improvement in the gastric pH values after vonoprazan as opposed to the gastric pH values when the patient was on lansoprazole, and since as well in the esophageal pH values, we do not see much significant differences between the esophageal pH after vonoprazan and lansoprazole. Similarly, in a patient with more severe grade D erosive esophagitis, again, vonoprazan was able to bring up the intragastric pH values to above 4, significantly better than lansoprazole. So in summary, amongst these 19 patients who failed to respond to PPI, we see that for those who had Vonoprazan 20 milligrams, 60% were able to achieve healing, and amongst 40 milligram group of Vonoprazan, 71.4% of these patients achieved response to Vonoprazan. And these were patients who failed to respond to conventional PPIs. The use of Vonoprazan in patients with PPI refractory reflux disease who continued to have symptoms of heartburn regurgitation on the GSRS rating score, as shown in this study, where they underwent pH impedance studies on conventional PPIs, and despite conventional PPIs demonstrating evidence of ongoing high acid exposure, they were then converted to receive Vonoprazan, and during Vonoprazan, they underwent a second pH impedance monitoring, this time on Vonoprazan. And if we compare the pH impedance values of these subjects who received PPIs compared to Vonoprazan, we see that the median percent of time that the gastric pH was less than 4 was significantly lower in the Vonoprazan treatment group. The nighttime and daytime gastric acid exposure was also significantly lower, and we see a lower number of acid reflux episodes, and this translated to an improvement in symptoms of heartburn and regurgitation amongst the Vonoprazan treated group. And the efficacy of Vonoprazan as the maintenance treatment up to 48 weeks was very elegantly demonstrated in this landmark study, which was one of the first in Japan to evaluate the long-term efficacy of the maintenance therapy with Vonoprazan. These were patients who had failed to respond to conventional PPIs. They were then given Vonoprazan 20 milligrams to induce healing of reflux esophagitis, documented on endoscopy. So after they received endoscopic healing with Vonoprazan 20 milligrams for 4 weeks, they were then given maintenance therapy with Vonoprazan 10 milligrams for 48 weeks, with symptom evaluation scores using the FSSG and the GSRS for up to 48 weeks. Before Vonoprazan, a substantial proportion of patients had erosive esophagitis from grade A to grade D. And following 48 weeks of maintenance Vonoprazan therapy, a substantial proportion of patients, close to 86%, maintained endoscopic remission after 48 weeks of Vonoprazan. And as well, the cumulative non-relapse rates is as shown, and with significant beneficial effects in their symptom scores measured with FSSG and the GSRS score. So a very recent systematic review and meta-analysis looking at PCAPs versus PPIs amongst patients with severe grades of reflux esophagitis, looking at the sucra scores. The higher the sucra or the surface under the cumulative analysis score, the higher the sucra score, the better the drug. And this network meta-analysis compared Vonoprazan with other PCAPs as well as other PPIs. And it showed the highest sucra score for Vonoprazan in terms of the initial treatment phase to induce healing of grade C and D reflux esophagitis, as well as the maintenance treatment in patients who had healed reflux esophagitis. And we see the highest sucra scores again with Vonoprazan compared with other PCAPs or other PPIs. Unlike Helicobacter pylori and reflux disease, there's less evidence for peptic ulcer disease. Some studies have looked at the comparison of Vonoprazan versus lansoprazole in the healing of peptic ulcers, and the systematic review and meta-analysis showed that there was no difference between Vonoprazan and conventional lansoprazole in the healing of peptic ulcers. So not much data for peptic ulcer disease up to this point in time. Lastly, safety issues will always be in the back of our minds, especially with such a potent acid suppressant. And this is illustrated in the 3-year interim analysis of the VISION trial, which is a randomized phase 4 open-label parallel group multi-center study conducted in over 33 centers in Japan, comparing the safety benefits of PCAPs as opposed to lansoprazole in patients who are receiving long-term maintenance therapy for erosive esophagitis. This is an ongoing study, and the interim analysis has shown that none of the patients, whether in the vonoprazan group or the lansoprazole group, had any malignant alteration of the gastric epithelial cells, no significant difference in treatment-emerging adverse events. We see that gastrin levels, pepsinogen levels, chromogranin levels do increase for the vonoprazan group compared to the lansoprazole group, but the levels taper off after week 108. And more significantly, the histopathological evaluation of these studies showed that there was no malignant alteration, no neoplasm or dysplastic alteration of the gastric epithelial cells for vonoprazan and lansoprazole. So adverse events have not been shown to be different comparing vonoprazan with PPIs. However, in the marketing labels for vonoprazan, we do acknowledge precautions with the use of vonoprazan, being such a potent acid suppressant drug. Bone fractures have been reported, malabsorption of vitamin B12 caused by hypo or acrohydria, hypomagnesemia leading to low calcium, low potassium, and fundal gland polyps have been reported with the use of vonoprazan. And more importantly, something that is always at the back of our minds is the metabolism of clopidogrel and the potential interaction of vonoprazan with clopidogrel. Vonoprazan is an inhibitor of CYP2C19. However, clopidogrel requires CYP2C19 to be activated and to exert its antiplatelet effect. So similar to PPIs, there is potentially a reduced concentration of the active metabolite of clopidogrel with vonoprazan, similar to PPIs. And lastly, just to share with you a patient that I've been managing for the last few years. This is a 62-year-old Chinese male whom I've been following up for close to 10 years. And as you may know, the prevalence of Barrett's esophagus is quite significant amongst Chinese population. And this was his endoscopic view at the beginning. He presented with classical reflux symptoms. He had been obtaining branded Nexium. We do not have branded Nexium in our hospital. He had a daughter who worked in Australia, and he was getting very good Nexium, the original esomeprazole from Sweden, and he was self-medicating with esomeprazole 20 milligrams BD, not the generic version. He failed to achieve symptom relief, and he had even doubled his dose of esomeprazole to 40 milligrams BD with prominent symptoms at night. Nocturnal acid breakthrough was a symptom. He was symptomatic, and he was also giving himself Gaviscon in addition to Nexium to try to control his reflux symptoms. And because he was on Barrett's esophagus surveillance, in one of his surveillance endoscopies, he unfortunately developed low-grade dysplasia in one of the tongues of his column. Low-grade dysplasia was proven with the histopathologist, and this was proven on a surveillance endoscopy a few years later, for which he underwent an endoscopic mucosa resection, as shown in this diagram. One of our intervention endoscopists did an EMR of the dysplastic region arising from long-standing Barrett's esophagus, and this was followed by a series of radiofrequency ablations in order to ablate the remnant islands of columnar mucosa. And more significantly, in 2019, vonoprazan was approved in our hospital, and I was able to give him vonoprazan 20 milligrams regularly, and with that, he completely experienced a relief of his symptoms. He did not have nighttime symptoms. He did not require Gaviscon. And after a series of ablations and ongoing vonoprazan, the most recent endoscopy showed a complete resolution of his intestinal metaplasia. There was nothing to biopsy on his esophagus. So in summary, ladies and gentlemen, we have shown that P-caps of vonoprazan from a different mechanism of action produces a rapid, strong, and sustained acid inhibition after administration, even within the first dose. It is not affected by polymorphisms of CYP2C19. It is able to achieve a rapid and sustained acid suppression, and it has been proven for the treatment of Helicobacter pylori, as well as for gastroesophageal reflux disease, with very promising results coming in from the US in the use of on-demand Vonoprazan for non-erosive reflux disease. And with this, I thank you for your attention.
Thank you, Dr. Ang. It was super excellent talk. In fact, we had few questions in the mind. I was actually planning to ask to my panelists, but most of the answers are very well described by you. But still, actually, as a carry-home message from the panelists, I'll start the ball rolling. So I'll ask Dr. Roy that, as Dr. Ang has actually, in detail, she has told us about the mechanism of action of PPI and PCABs. So what is the actually difference of action? Both are actually acting to reduce the acid output. But what is the basic mechanism of action, the difference between PCABs and PPI, and what is the advantage of the PCABs over PPI as far as the mechanism of action is concerned?
Thank you, Dr. Sir. Dr. Ang has really told us so clearly all about the mechanism of action and the differences between the two. And one can easily say that the prodrugs, that means PPIs, need a active parietal cell to act, and it has to be converted into sulfonamides, and also then it will act on the, so it will need the drug to be activated, and after that only the action will start. Whereas in the PCABs, the most important thing, it is not a prodrug, it is active as soon as it reaches the parietal cell in the canaliculi. It does not need any activated parietal cells. Inactive parietal cells will also get a blockage of the H-ion potassium ion ATPase, and that is going to be active immediately after it has been taken. Another important thing is that the PPIs are unstable in the acid milieu, so they will get destroyed earlier in the acidic milieu. So it has a lesser action as compared to the PCABs, and the PCABs are blocking all those proton pumps which are even not active, and they are going to be blocked even if they are not active. And secondly, it is a reversible blockage, whereas PPIs have a irreversible blockage. So 50% of the proton pumps which are being newly synthesized in the night by the parietal cell, they are usually not getting blocked by the PPIs, whereas the PCABs, they are still present there and they are in the reversible form. So they will go and block the newly synthesized ones. And one of the most important things which she has told very clearly, that they start functioning and within few hours, that means within 4 hours, you have almost a good acid suppression in about 80% of the patients. So it is going to be active and on the first day of the treatment, whereas PPIs will take longer action. And this is one of the most important thing, that means you start relief not on the 4th or 5th day, but on the first day and within few hours of the treatment, which she has very rightly told that in any RD, the PPIs, the effect is low, almost 60% will have response, not others. But in case of PCABs, any RD patients are also going to get very good effect, and that effect is going to be translated even after the healing or the symptom relief has occurred. You have stopped the drug, but again, whenever they need the drug, the action will start, and that's a very important point which she has told. So these are the few of the important ones which are very important.
Thank you, Dr. Rai. Actually, you have nicely summed up what Dr. Yang has said and what are the possible advantages of PCABs on PPIs. Now I'll go to Dr. Chetan that there are certain differences as far as metabolism of these two group of drugs, PCABs and PPI is concerned. And what are those differences which make the difference of Vonoprazan, these PCABs better than the PPI as far as the metabolism is concerned? Right from the point they are taken orally, then they get absorbed, then go to the liver, to the plasma, and then ultimately to the cell. So, what is the difference between the two groups, and what caches positively as far as PCABs is concerned over PPI?
So the most important thing for me is first is that its action is independent of the meals. Irrespective of whenever you take it, its action will be exerted as compared to the PPIs. The second most important thing for me is that its half-life is very long and its action lasts for more than 24 hours, almost 24 hours. So this takes care of actually the night burns or night refluxes which one usually gets. So in clinical practice, these are the two most important things, according to me, which scores over the PPI.
So it takes care of because of a longer half-life, it takes care of the whole day.
Yes.
And it is not getting affected by the meals.
Exactly.
So you can take any time.
So many times
on-demand therapy, so anytime you can take it and get the advantage.
Exactly. So that is, according to me, the most the best thing about this particular drug, that you can take it at any time. Many times patients forget to take it prior to meals, half an hour prior to meals, and then they wonder what is to be done. So this is the beauty of this particular drug.
Yeah, I mean, those are the advantages which are characteristically, better off with PCABs as far as compared to PPI. Now I'll go to Dr. Kote to, in short, Dr. Ang actually mentioned about the long-term side effects and precautions which are being, by the drug companies which are being given for a long-term use of these PCABs. So I want to ask you that what are the long-term data as far as literature is concerned for, with PPI there was a lot of hue and cry as far as, the anemia is concerned, the calcium metabolism, the fractures, and magnesium absorption. So what about PCABs if they are being taken for a long time?
Even though all the complications has been mainly because of the acid suppression, and which is sustaining for longer time. So when compared to the PCAB sources, the routine PPIs, it's almost the long-term impact will remain same, except that there'll be mild superiority or the inferiority of the PCAB sources, the normal PPIs. If you look into that way, these are some of the things are like which are more common with the PCABs will be even though they are much superior in action, faster in action, longer duration of action, more potent acid suppression, but some of the side effects which are more common with PCABs will be kidney injuries, like suppose if the person is susceptible, already having an acute kidney injury, or in a long-term CKD who is there in the borderline above 2, there the creatinine increase can be much faster when compared to routine PPAs, and also there can be an associated hypokalemia or hyperkalemia can be higher, but which is when compared to routine PPA, the complications what we expect, the Clostridium difficile as well as the vitamin B12 and the iron deficiency and the osteoporosis and the rebound acid hypersecretion, which are less in case of PCABs when compared to the other routine PPAs. However, but some of the other things which are being shared with both groups, like PCABs versus normal PPAs, like you'll be having the B12 deficiency, almost they say, literature say it is almost both are same only, but however some of the literature say it is lesser in PCABs when compared to the routine PPA, and hypomagnesemia is more common with our routine PPAs when compared to the PCABs. However, the calcium absorption, many data is this way and that way. Say some people says it is only a people who are at a fragile or when the bone mineral density is very low, then this PPI will predispose for that. Other than if the patient is not having any low BMI or low mineral density, then it might not add any much with respect to the fragile fractures.
Nicely said. Dr. Girish, I'll come to you now. The gastroesophageal reflux disease, as far as India is concerned, the class C and D, LA class C and D, are very less common. And most of our patients, they are non-erosive type, or they fall into the category of A and B. So what you propose is the future of treatment, because already PPI have a very good role and they are very effective in such group of patients. And Dr. Ang has said that the PPI have a better role in patients who have got a severe form of reflux disease. So I want to ask you that what is the future of these PCABs in India as far as these actually milder form of reflux disease are concerned?
Exactly, sir. So what the esteemed speaker has already illustrated, that if it is a milder variety of GRD, type A and B, usually the efficacy of PCAP and the PPI are almost same. There is not significant differences in between both of them. As only 30% cases having erosive esophagitis, and which is less common in India also. So I feel PPI and Vonoprazan, they might be equally efficacious for milder variety. And of course, what the data says, in case of non-erosive reflux, the Vonoprazan is being compared with the placebo, but not with the PPI. So I feel it should be PPI versus Vonoprazan for treatment of the NERD. So I feel that if the gray zone exists, if that study undergoes, then only we can state actually whether for NERD, this Vonoprazan is better for in comparison to PPI.
Very good. Now, there are few questions to Dr. Ang. One is actually, we are getting patients who come with active ulcer disease with GI bleed. Now, these patients, is there an availability of intravenous Vonoprazan in Japan, Korea? Because these PCABs are being used for a long time. So we are not sure about it. So whether the intravenous preparations are available for such patients?
Not that I'm aware of. We do not have intravenous Vonoprazan, and I'm not aware of it being in Japan. I think that's similar to some of the PPIs like Period, Rabiprazole, and I think Rabiprazole has no intravenous version. So usually when they come for GI bleeds, it's either IV pantoprazole or IV esomeprazole. So I do not have intravenous Vonoprazan, and I'm not aware of it in Japan, but please correct me if I'm wrong.
Yeah, okay. And there is a question in the chat box that what is the management plan should be there in recurrent H. pylori infestation after receiving 8 to 12 weeks of Vonoprazan?
So which means for the data for second line and third line Vonoprazan based triple therapy is gray. And most of the data coming out now has been retrospective observational studies in Japan. So not much data on that, I think also because it's new and it's difficult to randomize these patients to Vonoprazan or PPI because they really failed conventional first line. So I think there's not enough data to conclusively say that we should be giving Vonoprazan for second line and third line therapy.
And what is the safety profile as far as in pregnancy and lactating mothers?
So based on the product, based on the product insert that I read through, no data for pregnancy, and it hasn't been used in kids at all. So the studies that have been done have been in adults above 18 years old. So we do not have data for pregnancy as well as for children and infants.
And In your clinical practice, you have started using Vonoprazan as a first-line therapy for H. pylori?
Yes, definitely. Yeah, so yes, I do have that. If they can afford Vonoprazan, I definitely do it. So as mentioned earlier, the treatment in our hospital for 7 days of Vonoprazan is expensive because it's the actual Vonoprazan, whereas we use generic PPI, so that's so much cheaper. So if patients can afford, I give 1 week of Vonoprazan. Success rates have been close to over 90%, way above
But
90%.
in Japan, they are actually prescribing in a higher dose of amoxicillin and Vonoprazan for 7 days. So they are actually giving 1,000 milligram of amoxicillin 3 times a day with Vonoprazan twice a day for 7 days.
Yeah, so the dual therapy is actually not standard of care yet, whether it's Japan or USA. And I think the controversy is also what dose of amoxicillin is high. Is it 1 gram twice a day, 1 gram 3 times a day, or 750 3 times a day? So that's actually very gray and it's not standard of care yet.
I'll ask panelists to have any questions for Dr. Ang, please.
My concern is, madam, in case of the refractory gastric and duodenal ulcer, what is the role of Vonoprazan? Whether any study exists in refractory gastric or duodenal ulcer, and also whenever the recurrent gastric and duodenal ulcer,
Yeah,
whether
that's the
Vonoprazan is going to help?
Yeah, that's the part that's not much. I think so far in the data that I presented, there was a meta-analysis for healing of ulcers that showed that it was non-inferior. But I don't think there are studies that have showed whether it's beneficial for refractory. I think it's just because there's just not enough patients to recruit them in a randomized fashion.
Dr. Ang, Dr. Ang,
Yes.
are there some studies that in a upper GI bleeding from duodenal ulcer or gastric ulcer, can Vonoprazan be given orally, and what are the effects?
I would think that in the acute setting when patients are bleeding, we give intravenous because they are new by mouth. So I would foresee that if we were to do a study for bleeding ulcers, it would be after the acute bleeding episode. Because when patients are fasting and bleeding and we do emergency endoscopy, it's not possible to give them Vonoprazan. So they usually by default will get their intravenous esomeprazole or pantoprazole. And perhaps we could oralize them to Vonoprazan on discharge and then see the healing rates.
Yes.
Dr. Kote, you have any questions for Dr. Ang? Unmute yourself.
Yeah, no, sir, no.
He's being kind to me.
Yeah. So I wanted to ask Dr. Ang, is there any role in portal hypertensive gastropathy?
Not yet, not yet. I think that might be a problem because we do exhibit caution with liver dysfunction and cirrhotics for Vonoprazan. So amongst the portal gastropathy, they would usually have some degree of cirrhosis giving portal hypertensive gastropathy. So that might be a problem. But I guess there's a subgroup of patients with GAIF without portal hypertension who might benefit. But so far in my practice for the GAIF patients, I seldom give PPI unless I have done APC and I want to improve the APC-induced ulcer healing.
The initial PCAPs were withdrawn in Japan.
Yes, because
of
liver
the
toxicity.
hepatotoxicity, actually.
Yeah. So
And patients who have got decompensated liver disease, as such, they recommend for half the dose.
yeah, that's right.
Ma'am, I have a question. With respect to the malabsorption is concerned, most of the malabsorption, either it is calcium, magnesium, or iron deficiency, or a B12 deficiency, all are usually will be secondary to the acid suppression per se.
Yes,
and
that's
because
right.
so is there any difference in these things with compared to Vonoprazan versus other
yeah,
PPIs?
that's the thing, right? Like in the analysis that has been published, they only focus on like the gastrine tumors, but no one has actually looked at calcium. I'm not sure, but maybe the study can be done, but not to my knowledge whether the calcium and magnesium are significantly different between PCAPs. But I think it's really exciting because in India, you have such a large population who now have access to PCAPs. And I foresee many more papers coming out and overtaking Japan.
So I have one
Because
question,
some of the
madam.
studies they mention that.
Madam, I have a question. Sir, whether any means anaphylaxis or any allergic reaction occurred with Vonoprazan?
Yeah, I think the product in insert has mentioned some cases of Steven-Johnson syndrome.
Yeah.
Yeah.
Really, it can happen.
Yes, but
So that
just
is
like
my
any
point.
drug, I guess there's always it's always potentially a problem, but not
Madam, no
hopefully
risk
not.
of interstitial nephritis, acute
Yes.
interstitial nephritis.
Has also been reported. Yes.
I think I'd like to sum up at this stage to say that these PCAPs are actually the new kid on the block, and distinctly, actually, we had been using PPI for now more than 30 years. So, in clinical practice, we are much used to PPIs, but now there is a drug which has got a similar indications for treatment, but added advantages on the mechanism of action. So, at the same time, the limitations which Dr. Ang has actually, told about the PPIs are being actually covered up by these new PCAPs. So, the indications for a severe form of reflux disease and those with PPI resistant form of reflux disease, there is a clear cut indication for using Vonoprazan. But according to the literature which she has told us, even patients with non-erosive type of reflux disease, even patients with on-demand treatment, Vonoprazan is becoming a better choice than PPI. And the safety profile, which we expect that the long-term use of a more potent drug may have some more side effects. I think the data is not very robust, but still we have to go a long way to see the long-term side effects of PCAPs as compared to PPI. The final comments by Dr. Ang, and then we wind up.
Okay, so I think PCAPs are a useful alternative to PPIs. They have beneficial effects, but we also have to balance cognizant of the side effects and the long-term potential harm from high acid suppression. There's emerging data to use PCAPs for on-demand therapy for non-erosive reflux disease and potentially beneficial amongst sclerostin-resistant strains of Helicobacter pylori. If PCAPs were available, I think that there's a lower threshold to use, but in this part of the world where I am, where we don't have branded generics, cost benefit has to be an important consideration. Not everyone in the public hospital system in Singapore has access to PCAPs because it's expensive. So I weigh the pros and cons. The patients can potentially be treated with a short course of Vonoprazan, whether it's reflux or HP, then there's nothing to stop me. Of course, we have to be careful of interstitial nephritis and patients with abnormal liver function. So overall, very exciting days ahead. And I foresee that, I mean, in India, there's just so much more that can come out from all the studies once you start using Vonoprazan.
Thank you, Dr. Ang. Now I'll actually hand over the proceedings to Ajanta Pharmaceuticals for the final concluding remarks.
Sure, sir. Thank you very much to this panel. I will request our head for sales and marketing, Mr. Amey Kumar Padi, to basically give the formal vote of thanks.
Thanks, Dr. Deepak. Good evening. As we conclude today's enlightening ISP, it is my privilege to extend our heartfelt gratitude to on behalf of Ajanta Pharma to everyone who contributed to its success. First and foremost, we extend our heartfelt gratitude to Dr. Daphne Ang, our esteemed speaker today. Madam, your presentation on Vonoprazan, redefining acid peptic disorder management, has been both enlightening and inspiring. Your deep knowledge, coupled with your ability to communicate complex ideas in an accessible manner, has significantly enriched our understanding and providing us with new perspective on Vonoprazan in the management of acid peptic disorder. Madam, we truly appreciate your dedication and the time you took out of your busy schedule to share your expertise with us. We extend we extend our sincere thanks and appreciation to our moderator, Professor Dr. Sandeep Nijavan. Sir, your skillful guidance ensured that our discussions were both being engaging and informative. Equally, we would like to express our sincere thanks and appreciation to our esteemed panelists, Dr. Ramesh Ruprai sir, Professor Dr. Chetan Kantaria sir, Dr. Sarath Kote sir, Professor Dr. Girish Kumar Pati sir. We are incredibly grateful for your contributions. Your diverse perspective and in-depth discussion have provided us with a comprehensive understanding of the topics covered. Thank you for your dedication and spending your precious time to share your expertise with us. We also thank to our doctor attendees who joined us from various parts of the country, taking your time out from your busy schedule. Your presence, attention, and engagement were crucial in making this event a resounding success. Your question and interactions added depth to the discussion, making this truly a collaborative and enriching experience as well. Thanks to Team Ajanta and our event partners for their relentless effort in putting this event together and making it a mega success. Just to inform, we have almost 3,500 participants, viewers attended, and has made it a mega event. Thank you very much, all the doctors. Thanks a lot, and wishing you a pleasant evening ahead.
Thank you so much. Thank you, Dr. Ang. Special thanks.
Thank you for helping me.
Thank you, Dr. Ang.
Thank you. We should take a picture.
Yes, we should.
Virtual picture should be there.
Let me take a picture.
3,500 participants is definitely noticeable number. Team Axicon, are we still live or we've gone offline?
Can I take a picture with all the panelists?
Yeah, definitely.
I'm trying to open my pathetic camera on my phone.
Can do the print screen also.
Right,
It will take the photograph.
We will share your doctor. We will share in the group.
Thank you.
Got it.
Thank you so much. Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you. Take care.
Good evening. Thank you. Thank you, everyone.
Thank you.
Thank you, sir. Thank you.
Team Axicon, I hope we are offline.